Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast, your free on-the-go source for radiology board review. On this episode, I will be discussing the pediatric kidney. This is a topic that has been requested by several listeners, and I think this is a fantastic topic to review. To prepare for this episode, I realized there is a lot of information here, and this is all really high-yield information. This will be a multi-part series that will be at least 2 episodes in length. Once I have presented these episodes, I will make available to you a free downloadable study guide on this topic. You can download study guides on many topics that I have covered on prior podcast episodes on my website, theradiologyreview.com. Also, as a reminder, I am posting tips for the ABR physics portion of the ABR core exam on Twitter and Instagram at RadRevPodcast. So follow me there and check that out. Finally, I wish to present one tip for those who have the ABR core exam in the very near future, and I suppose for those who are studying for the ABR core exam at a more distant date as well. And that tip is to not sweat the small stuff, but worry about the big issues. I've had many listeners contact me recently online asking about minute differences between one number they saw in one source versus another number that was stated in another source. For example, differences in radiation dose thresholds for deterministic effects that vary slightly from one source to another. Or else, I have had many listeners contact me online over recent months asking me about specific questions they have encountered on question banks that deal with topics that are really, when you get down to it, controversial in radiology and for which no single answer truly exists because there are variations in normal practice patterns. My advice for these types of issues are that the ABR core exam will not ask you questions on subjects that have not been definitively answered, and if there is a specific way to perform imaging or do something in radiology where multiple avenues are reasonable, the ABR core exam will not ask you to choose between several reasonable alternatives. The ABR core exam, to my understanding and from my experience, tests you on questions where there truly is a single best answer. In terms of specific numbers, they will tend to give you a range that is broad enough that all reasonable numbers or estimates will be included within that number range. So, for example, if there is a deterministic effect that one source may state happens after a 5 milligray dose has been delivered and another source says it is 7 milligrays, the ABR core exam will not ask you a question where option A is 5 milligrays and option B is 7 milligrays. They may give you a question that has ranges such as 0 to 4 milligrays, 4 to 8 milligrays, 8 to 12 milligrays, above 12, and so forth, so that the range being tested presents the reasonable range that encompasses the variation that exists in our knowledge, in the published literature, and in actual practice. I hope that makes sense and may help alleviate some anxiety for some of you. With that said, let's get on to the questions and answers on the pediatric kidney for the ABR core exam. First question for this episode: what is the Potter sequence? The Potter sequence results when there is decreased urine output in utero, resulting in oligohydramnios, which, as a reminder, is too little amniotic fluid, and this causes potentially fatal complications that can include hypoplastic lungs, intrauterine growth retardation, and characteristic facial abnormalities that include things like a flattened nose, as well as limb abnormalities to include clubbed foot. Potter sequence can occur from any cause of prolonged oligohydramnios The most classic etiology on the ABR core exam would be bilateral renal agenesis. Potter sequence could also result from other causes of oligohydramnios that include posterior urethral valves or autosomal recessive polycystic kidney disease. Next question. What is Vectoral? That is spelled Vactterl. What is Vectoral? Vectoral is an association and not a syndrome. Basically, Vectoral describes common congenital anomalies that are all associated with one another. Vectoral stands for V, vertebral anomalies, A, anal anomaly, typically an imperforate anus, C, cardiac anomalies, T, trachea esophageal fistula, or E, esophageal atresia, R, renal anomalies, and L, limb anomalies. Make sure you know Vectoral front and back for the ABR core exam. An interesting fact is that if both limbs are abnormal in the setting of a Vectoral association, you can also assume that both kidneys will be abnormal in some way. And if only one limb is involved, usually only one kidney will be involved. Vectoral associations are very high yield for the ABR core exam. Next question. What renal abnormality is associated with Caroli syndrome? Caroli. What renal abnormality is associated with Caroli syndrome? Caroli syndrome is an autosomal recessive abnormality with classic cystic intrahepatic biliary ductal dilatation consistent with a Todani 5 classification. If you are not familiar with Todani classification, that is also a high-yield topic for the ABR core exam. Please look it up. Caroli syndrome is associated with polycystic kidney disease, and this polycystic kidney disease associated with Caroli syndrome can be autosomal dominant polycystic kidney disease or autosomal recessive polycystic kidney disease, as well as medullary sponge kidney. So potentially two answers here. Polycystic kidney disease and medullary sponge kidney are both associated with Caroli syndrome. Remember that the central dot sign is classic for Caroli syndrome, in which you see the enhancing portal vein centrally, surrounded by these cystic, dilated bile ducts. Next, does autosomal recessive polycystic kidney disease classically present with large or small kidneys? The answer I am looking for is that autosomal recessive polycystic kidney disease classically presents with enlarged kidneys. And these enlarged kidneys contain innumerable renal microcysts, and this causes renal dysfunction with up to 1/3 of affected neonates not surviving the neonatal period due to pulmonary hypoplasia. Autosomal recessive polycystic kidney disease is also associated with hepatic fibrosis, and I think it is interesting that the degree of hepatic fibrosis is often inversely correlated with the degree of renal involvement. So, for example, if a patient with autosomal recessive polycystic kidney disease has more severe hepatic fibrosis, that would typically mean that the patient has less severe renal disease, and vice versa. If hepatic fibrosis is severe, this can lead to portal hypertension and even death. So remember, autosomal recessive polycystic kidney disease can be fatal for a variety of reasons that can include oligohydramnios causing pulmonary hypoplasia as part of Potter sequence, or severe renal failure, or hepatic fibrosis with severe portal hypertension. On board exams for autosomal recessive polycystic kidney disease, be on the lookout for a history of hypertension in a neonate and renal failure with smoothly enlarged and echogenic kidneys on ultrasound. Next question. What common associations are found with unilateral renal agenesis? As a reminder, bilateral renal agenesis results in Potter sequence, whereas unilateral renal agenesis may initially be asymptomatic. However, there are very common gynecological associations with unilateral renal agenesis, and the majority of genetic females with unilateral renal agenesis will have genital anomalies. In genetic males, anomalies in the setting of unilateral renal agenesis can also be present, such as ipsilateral absence of the epididymis and ipsilateral absence of the vas deferens, or an ipsilateral seminal vesicle cyst. Unilateral renal agenesis is also associated with an absent ipsilateral ureter and absent ipsilateral hemitrigon of the bladder. Next, how on imaging can you potentially differentiate a surgically absent versus a congenitally absent kidney? There are multiple potential answers to this question, but the main one I am looking for is the pancake adrenal sign, in which the ipsilateral adrenal gland appears elongated and pancake-like. Obviously, if you see surgical clips in the renal fossa, that would point you towards surgical absence of the kidney, and the clinical history will also be informative. But essentially, if the kidney is congenitally absent, the adrenal gland will look different. It will have this pancake adrenal sign, and if the kidney is surgically absent, the adrenal will demonstrate its typical appearance. Next, what is the Meyer-Rokitansky-Kuster-Hauser syndrome? I'll try to say that one more time. Meyer-Rokitansky-Kuster-Hauser syndrome. What is this? Meyer-Rokitansky-Kuster-Hauser syndrome is associated with Müllerian duct anomalies to include absence of the uterus versus an atretic unicornuate uterus, as well as absence of the upper 2/3 of the vagina with normal external female genitalia and unilateral renal agenesis, or other renal anomalies such as a horseshoe kidney, and possibly also vertebral anomalies. Remember again, Vectoral. Key here is to remember that Meyer-Rokitansky-Kuster-Hauser syndrome is associated with Müllerian duct anomalies, including potential absence or otherwise abnormal unicornuate uterus, in addition to absence of the upper 2/3 of the vagina with normal external genitalia. Next, what are classic potential complications of a horseshoe kidney? Classic potential complications of horseshoe kidney include renal trauma due to an abdominal force causing compression of the horseshoe kidney centrally over the underlying vertebral body. Remember, the kidneys normally lie on either side of the vertebrae. In the setting of horseshoe kidney, a portion of that horseshoe kidney will overlie the vertebra, and that portion of the kidney is at risk for trauma by being compressed between an object or force and the vertebrae. Other complications include ureteropelvic junction obstruction, recurrent urinary tract infections, and renal stones. Patients with horseshoe kidney also have a much higher risk of developing Wilms tumor and transitional cell carcinomas, as well as renal carcinoid. So remember that horseshoe kidney is associated with development of these types of malignancy. Horseshoe kidney also has an association with Turner syndrome. Next question. What is crossfused renal ectopia, and which kidney is typically ectopic? Crossfused renal ectopia occurs when one kidney crosses midline and fuses with the other. The ectopic kidney is usually the kidney that is more inferior, most commonly the left kidney that crosses and fuses with the right kidney. Associations with crossfused renal ectopia include hydronephrosis, recurrent infections, and renal stones. Next question. What are the classic features of prune belly syndrome? Prune belly syndrome consists of absent abdominal musculature, hydronephrosis and hydroureter, and cryptorchidism. The cause of the cryptorchidism is the massive urinary bladder distension that prevents normal testicular descent. Remember that prune belly syndrome is also sometimes called Eagle-Barrett syndrome, and this syndrome has vectoral associations. Key again with prune belly syndrome is to remember the triad of absent abdominal musculature, hydronephrosis/hydroureter, and cryptorchidism. Next, what is the most common congenital anomaly of the genitourinary tract? The answer I am looking for is congenital ureteropelvic junction obstruction. That is the most common congenital anomaly of the GU tract. This congenital ureteropelvic junction obstruction may be bilateral in something like 20% of cases, and the treatment for advanced congenital ureteropelvic junction obstruction is surgical pyeloplasty. Next question, true or false? Neonatal renal vein thrombosis is associated with maternal diabetes. The answer here is true. Remember that left renal vein thrombosis is most common, and if you have acute renal vein thrombosis, expect renal enlargement. If you have chronic renal vein thrombosis, expect renal atrophy. And that leads us into the next question. What is the most common cause of neonatal renal artery thrombosis? The answer I am looking for is umbilical artery catheterization. That is the most common cause of neonatal renal artery thrombosis. Next, what are top causes of congenital megaureter, which is also called primary megaureter? Top causes of congenital megaureter include an adynamic segment of the distal ureter, ureterovesicular junction reflux, or simply being idiopathic. In the setting of congenital megaureter, hydronephrosis may or may not be present, but is most common with the distal adynamic type of congenital megaureter. Next question. A, quote, reverse J, end quote, or, quote, fishhook, end quote, appearance of the ureter in an intravenous pyelogram may be a sign of what entity? The answer I am looking for is that a reverse J or fishhook appearance of the ureter on an intravenous pyelogram may be a sign of a retrocaval ureter. A retrocaval ureter results from a developmental anomaly of the inferior vena cava that can cause partial obstruction of the ureter and may present with recurrent urinary tract infections. Next question. What is the Weightmeyer rule? Anybody who has studied for the ABR core exam for any significant amount of time certainly will encounter the Weightmeyer rule over and over again. Let's make sure we all have this clear. The Weightmeyer rule is a must-know rule for the ABR core exam and describes the anatomy of a duplicated renal collecting system. The Weightmeyer rule states that the upper pole of the duplicated collecting system will have an ectopic insertion that is located inferior and medial on the bladder, and the upper pole is associated with a ureterosil and obstruction. The inferior pole, on the other hand, will insert superior and laterally compared to the upper pole moiety and is prone to reflux. A way I remember this is I remember the two letters IR, similar to interventional radiology, IR. And because that is such a familiar two-letter combo for radiologists, I remember with the Weightmeyer rule, IR meaning inferior refluxes. The inferior pole is the one that refluxes. I also remember that the upper pole has a ureterosil. Notice that both of those are UU. So I remember IR for inferior pole refluxes. I remember upper pole has a ureterosil, UU, and this helps me remember that the upper pole is also prone to obstruction because it is the ureterosil that typically would cause that obstruction. It is absolutely key that you have the Weightmeyer rule and these associations down. One more time. The upper pole moiety has an ectopic insertion, inferior and medial on the bladder, and this upper pole moiety is associated with a ureterosil and obstruction. UU, upper pole ureterosil. The inferior pole inserts superior and laterally compared to the upper pole moiety, and is prone to reflux, IR, inferior moiety refluxes. Next, what is a ureterosil? I proceeded with the Weightmeyer rule, assuming that you all know what this is, but let's make certain that is the case. A ureterosil is a cystic ballooning of the small intravesicular portion of the ureter, intravesicular as in within the bladder wall. And if you get cystic ballooning of the intravesicular ureter within the bladder wall near the insertion of that ureter, that easily obstructs that ureter. And this is thought to be a source of obstruction of the ureter at or near the ureteral orifice. Next question. What is the top cause of urethral obstruction in newborn males? The answer I'm looking for here is posterior urethral valves. This is another very high-yield entity for the ABR core exam. A posterior urethral valve is a congenital obstruction near the posterior urethra. On a VCUG, look for an abrupt caliber change between the dilated posterior urethra and the normal-sized anterior urethra. On imaging such as ultrasound or MRI, the appearance of the bladder with the dilated posterior aspect of the urethra can give you a keyhole appearance, and that is a very common phrase associated with posterior urethral valves, keyhole appearance. If you don't know what that looks like, you need to look it up so that you know. And that is the appearance that you see from the bladder being positioned next to a dilated posterior urethra. In the setting of posterior urethral valves, if you see a perirenal fluid collection, you need to suspect that that could be a urinoma that has resulted from forniceal rupture due to the high pressure in the urinary system with resultant leakage of urine around the kidney, causing a perirenal urinoma. If posterior urethral valves are severe, this may be diagnosed in utero with findings of oligohydramnios and Potter sequence manifestations. If posterior urethral valves are less severe, then this may manifest initially with something like recurrent urinary tract infections due to vesicoureteral reflux that is also associated with posterior urethral valves. And final question for this episode. Are posterior urethral valves seen in newborn genetic females? The answer is no. A posterior urethral valve is a disease exclusively in anatomic males, and the reason why is that the obstructive tissue on the posterior urethra derives from Wolffian duct tissue and is typically sporadic, derives from Wolffian duct tissue. Posterior urethral valves are typically sporadic, though can be associated with some genetic syndromes, including Down syndrome. That concludes the questions for this episode. I will continue discussion of the pediatric kidney on the next episode of this podcast. As that episode is posted, I will also upload the free downloadable study guide on this topic to my website, theradiologyreview.com. I hope those study guides are useful for many of you. Thank you for listening to this episode. Keep up the good work. Continue to study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.